Okay, good afternoon. Welcome back to Favaloro Foundation University Hospital. We are waiting for all of you. I have to tell you the truth. It has been a very intense waiting minutes because some situation we have here that I want to show you in a few minutes. Let me introduce the team. Dr. Lev, Joaquin on my right side, Kevin, the X-ray technician, the same to Hernan, Matias, our nurse. Here is Valeria, who is the specialist product for shockwave, and also is Ariel behind me, who is the specialist from Minos device, and Dr. Navas and
George.
And
George.
And Dr. Jaime here, the two anesthesiologists working together because this is a very complex patient. So thank you for helping us in the morning. Let me show you the slides. I will share the case. The first slide, please. So behind in the control room, we also have Dr. Andres Rodriguez, who is our digital moderator, and he is always bringing the question from the audience. I think this case will bring a lot of questions to everybody. So next slide. So he is a young male, 67 years old, who presented in a control for hypertension, dyslipidemia, severe smoker with severe COPD with a minus renal failure. I will show you that he underwent coronary angiography in another center some years ago for an episode of chest pain, and he was diagnosed when only one vessel disease and medical treatment was indicated. In this summary information of this procedure, it is referred that he received an IVUS evaluation of the left main, which had at that time a minus or mild lesions. He also suffered from intermittent claudication. So in summary, it's in a panvascular disease with severe COPD, and also is a significant, he has a significant obesity, as you can see him on the table. Next. So the ECG is quite normal on the consulting room. All the blood tests are almost normal with some elevation of the urea and creatinine, and the echo Doppler evaluation show preserved left ventricular ejection fraction with some left ventricular hypertrophy. A stress test done in another center also was referred as negative stress test. It was stopped because he suffered from fatigue due to his pulmonary disease. Next. So this is the CT scan evaluation that we received with the patient for evaluation for an EVAR procedure. The patient was referred for our vascular surgeons, but they refused the patient for surgery and sent the patient to us to treat by endovascular procedures. As you can observe, there is a significant calcification in both iliac arteries, calcification on the left renal artery, 5-centimeter aneurysm, with some, thrombus, with thrombus irregularities inside the aneurysm. Next. So there you can observe the calcification of the vessel on the left of the panel, then the diameter of the aneurysm, which is 60. And this is for us an indication for treatment. Next. So he has an hostile proximal neck. It's a little bit conical with some thrombus in the posterior wall. So probably according to this neck, which is also short, according to the CT, not according to the angiography that you will see afterwards. Probably it's a patient that we can discuss which technique we should use, regular EVAR or think about endo anchors or chimney or something like this. I think it's not a candidate for a dedicated device, a branch device, because both iliac arteries are quite small and it's impossible to go through these vessels. Next. So this is the length of the aneurysm, which is 13 centimeters from the lower renal artery with a diameter of 60. Next. And this is the right iliac artery. The common iliac artery is 7 millimeters in length with a diameter of 5 in the narrowest part of the vessel with significant calcification, a concentric calcification there. And then we have a quite acceptable external iliac artery. Next. Something similar, but with a little less calcium on the left iliac artery, 5 centimeters in length, 9 millimeters in diameter. But the external iliac artery have a little bit more calcification with the site of stenosis, with 5 millimeters in diameter, with almost 180 degrees of calcification in this vessel. Next. So in summary, it's a young patient with a lot of disease, severe pulmonic disease, with hostile anatomy, coronary artery disease, and he was referred for EVAR after surgeons refused to open surgery for him. So this is our plan. Next. So we have decided to, this was our original plan to do EVAR for percutaneous vascular access with a surgical standby, of course. We decided to use again an ultra low profile device because this calcification. But we have thought and discussed with Dr. Lev before planning the patient to do predilatation with the intravascular lithotripsy balloon. So to do shock wave there, just to fracture this calcium and to facilitate the predilatation of the arteries and to facilitate the advancement of the both devices, the main body and then the contralateral branch. Next. So this is the minus device that we have introduced here in the last cases. And to 28 millimeters in diameter of the body, the device is 14 French. If you go higher with a bigger device like 29, 30, something like this, you have to use a 16 French device. So according to the next, according to the iliac artery, we have discussed with Ariel, our a specialist from Minus, and we have decided to go with the 14 French device, which is going to be 28 millimeters in diameter for the main body at the level of the proximal neck. Next. So this is the device in comparison with other device. In my opinion, it's probably impossible to cross these iliac arteries with the regular devices that we use here, like Enduran or Scenic or Zotec devices, which are bigger than this device. Next. And then some information about the peripheral lithotripsy balloon. We have chosen the 7, which is almost the bigger diameter of the balloon, but also we have 8. No, 7 is the biggest. The length of the device is 60 millimeters, sorry, and we have 300 pulses. According, we are living in Argentina. Sometimes to use a lot of new devices is quite difficult. So we have decided to use for this catheter half and a half, probably 160 or something like this on the right, which is more calcified, and then the rest of the pulses are going to be used for the left iliac artery. Next. So let's go back to the lab, and before discussing this strategy, I had to tell you what had happened in the 30 minutes that we were waiting here to do the procedure. First, advance very fast. We decided to use ProStar because the calcification guided by angio and echo, you see the calcium there. It's almost impossible to put the ProGlide there or the regular ProGlide that we have here. Remember again that this is not the new one. It's going to be at the end of the year. Next. So the same for the contralateral side. Next. We introduce the ProStar. Next. You can observe there the calcification. We try to put this wire that we use from the superficial femoral artery, but on the left side it was too small, impossible to deploy this wire, but this is a 12 French device. I think it's not going to be necessary. But here on the right side, which is our at least a selected entrance side for the main body device, we deploy this wire for protection just in case we have bleeding. So we were there. It was 11:30 or something like this. So 30 minutes before live. And the patient, when the blood pressure went down, it was extremely difficult to recover the patient with some ST depression on the monitor, on the ACG. That's why Dr. Jaime and Dr. Nievas worked together as an anesthesiologist. We introduced a central venous line on the left side of the patient for drugs. We did echo. The echo was, the left ventricular function was acceptable, but was extremely difficult to keep the pressure at acceptable blood level. So we discussed with Dr. Lev, and we decided to test the coronaries because undoubtedly something went wrong before starting the EVAR procedure. So show me this now, the next one. So when we did the angios, you can observe the calcification in the superior wall of the left main, very tortuous left anterior descending artery, and also the left circ, but without significant lesions. Next, we did another angio. Here it's a little bit confusing. The right is occluded with a good collateral circulation from septal branches. Next. And there you can observe a severe osteal lesion on the left main, and I think probably related with a pulmonary disease and some hypotension and some bad perfusion due to this lesion. The patient did not tolerate very well the anesthetic procedure. And after the discussion here again with Dr. Lev, we decided to proceed with IVUS evaluation of this osteal lesion, which was supposed to be evaluated in another setting and considered as a mild lesion. So probably if you can share the IVUS, let me see if we change the, I don't know if you can share here the IVUS, Hernan? No. Okay, okay. Let's see, please, this is the IVUS. So this was an emergent IVUS. The IVUS was coming from the proximal LAD. As you can observe there, significant calcification. The catheter jumped out, but there was a tight lesion on the ostium. Probably Dr. Andres has a picture of the lesion if you have it. So there it was 5 millimeters, the area, probably lower, probably it was not a perfect measure there, with a minimal diameter of the 23. Discussion again here in the room, and we decided to proceed with the left main implantation. Let's show the angio again.
With the 4.0 reference diameter.
Yeah, the distal reference, Gustavo said, is 4.5 or something like this. 4.0. Let's go fast because we don't have too much time. So we pre-dilated with a 3.5 non-compliant balloon at the ostial segment of the left main. You can observe there a significant improvement of the lumen. Next, we protected the left circumflex, and we went just for an ostial lesion. This is the shortest stent that we have it here, 4.0, 13 millimeter in length, high pressure inflation, 20 atmospheres. And this is the angiographic final outcome. And we have the IVUS, probably, if we go back to the IVUS. So the circ was okay. And this is the final IVUS, as you can observe there. The stent was perfectly opposed to the left main, well open. And I think it was not necessary to go for pot or something like this. It was 1 or 2 millimeter protrusion into the aorta that we are sure that the ostium was perfectly covered. So next, the angio. Let's go to the angio. We did the angiography before starting, just to check, and you can observe on the right of your panel a very tight renal stenosis. We are going to be close of the renal arteries for body device deployment. So we had to change our strategy again, and we decided to proceed to deploy the stent. Please show it very fast with the pre-dilate this lesion. And then we implanted the 6 millimeter stent at high pressure with an acceptable good outcome without not protruding too much into the aorta because, we had to deploy the graph exactly there. So, okay, that's it. Yes, stop the answer. Here we are now. You can share the hemodynamics. The HCG is perfectly stable. The blood pressure is perfectly stable. So I think left main PCI was the correct decision before proceeding with the EVAR. It's probably, I know that somebody will say, why not stopping here? But the patient is prepared. Everything is done. I think we had to continue because the procedure was very short, very good angiographic and IVUS outcome, very low contrast was used. And I think we are almost in a perfect condition to proceed. Gustavo, and for sure we can ask the audience for any other questions. So we are preparing the catheter for el lithotripsy. Gustavo is Dr. Levy is open. I'm going to prepare the connection here. The catheter is 014, so we have to introduce a regular J wire and then to put an 014 extra support and long wires. Give me the connection so we are not. It's okay. Yeah. Trae el inflator. Tenerlo ahí, Gustavo. Sacarle todo el gas. So it's very important, the preparation. Very slowly, please. Very slowly. And now, please aspirate. We have to retrieve all the air from the balloon. If not, we have to do it once again. Let's do it like this. Release. Wait. Aspirate again. Turn back. No. There. Okay. Aspirate again. Okay. So this is a very important step. And now we release very slowly. And now, once again, take this air out. Okay. And now we are okay. So we are going to start.
Like to show the catheter.
Yeah. Let me go through this 014 wire. The catheter has how many electrodes? ¿Cuántos electrodos? 5 electrodes. So the sparks induce microwave explosion with a big pressure there, as we showed in a coronary case that we did here on the left main, and produce a high pressure fracturing the calcium of the vessel. The central area or the central electrode is where we have more powerful inflation. So there we are exactly in the middle of the more significant calcification. Gustavo is going to inflate at 4. When the balloon is at 4, yeah. Now we are delivering, and here if you turn the machine to this camera, you will see the shock wave machine working. Okay. After 30 pulses, we have to inflate to 6. Now it's a quiet part of the procedure. We have to take the time, and it's time to ask Gustavo for the strategy and for what was going on before the procedure. 6. So Gustavo, would you have a deflate? 6 and deflate. Would you have done something different?
No, of course not. I think that it's a very challenging case in a high-risk patient with several comorbidities. So after performing coronary and renal angioplasty, I think that this is the right technique for this kind of patients. I think that the IVL will be very useful for this patient because the disrupt study 3 showed us very good results in TVAR and EVAR patients. So I think that it will be very useful.
So after 30, you have to inflate at 6.
6 now.
And yeah, deflate.
Okay.
Remember that we have discussed something here that for peripheral circulation is not necessary to deflate, but my intention was to deflate to move a little bit backward here to the external. Gustavo is going to inflate at 4 again. I'm going to deliver 30 pulses again. So you see on my right hand the light, which is on and off. You might hear some sound of the spark inside the balloon. The other, important comment probably is that you can observe this wire, which is for protection, which is side by side with the balloon, is not affecting the delivery of the energy. It's something also important to take 6, Gustavo. Deflate, to take into consideration, especially when you are doing a bifurcation or something like this on the coronary field. Is
4.
Again 4. So after delivering this energy, we are going to dilate with a 7mm balloon at a little bit higher pressure than 6 before preparing and introducing the EVAR device. So Andres, if we have some questions from audience, online audience, please don't hesitate and bring to us. So we are 180. So 6.
6.
We are going to do another one, and then we are moved to the other side. Yeah. 6, 4. Which is the
impact.
The impact.
Well, to prevent complications, severe vascular complications.
Well, this is an important question. Peripheral vascular disease has a negative impact on EVAR procedures on the long-term follow-up because it increases the risk of branch occlusion, especially for the contralateral side where the branch is small. But anyway, it's something that we have to deal with. We have to be sure that we have an acceptable runoff to deploy stent if it is necessary on the external iliac arteries. And then after the EVAR procedure, we check. We check with the echo Doppler evaluation during the follow-up, which is the ankle brachial index. And if it is too low, we study the peripheral circulation, thinking about the possibility of doing something endovascular to fix some obstructions there. So we are going to go contralateral. Okay. The balloon now has probably a high profile, but anyway, I think it's not going to be a problem to cross these lesions. Let me know when it's out. Please pull the wire. Here, more. Más. Okay, keep it there.
Yes.
Okay.
One of the common and worried problem of the EVAR is a vascular access. So with this technique,
let's go.
We can afford a serious problem of thrombosis and impossibility to access with the EVAR prosthesis.
We are 4 there. We are going to apply the energy. Well, ideally, you have to use all the balloon energy and the side you want to treat. Here we are showing to the audience our local limitations in Argentina. If without any restriction, 6, probably this would have been a patient to use an 8mm balloon, if you have it, deflate, on the common femoral arteries, and then 6 or 7 on the external iliac arteries. But I have to handle the situation just with only 1 balloon. So there you can observe some balloon indentation, but which is opening with the only 4mm atmospheres dilatation.
Balón 7.
La presión está okay. Okay, because here probably because the balloon is inflated, we are not having the correct blood pressure measurements. So please prepare the peripheral balloons, 7, the 2, and another inflator, so we can go fast. Because we have some time constriction due to all these limitations we had before starting the procedure. So at the end, this is going to be a left main PCI, left renal artery PTA, and hopefully also a successful EVAR procedure. It's something that we don't do never in the regular basis. This is a completely extraordinary situation.
6.
Okay, deflate. Okay, inflate once again. I mean, for intravascular lithotripsy, I don't think so. We don't have any absolute contraindication. Maybe I can ask Valeria. ¿Alguna contraindicación absoluta? No. No, not at all. Sí, dos. 2 balloons so that we can go
6.
faster. Deflate. Let's move for the last run. Okay. Let's go there. 4. I will not do angio because we have done some extra contrast in a patient with the previous some renal dysfunction. So I bet that everything is okay. And I will not do the angio. I just gonna go with the balloon to predilate the common femoral arteries. I will not inflate into the external iliac arteries, just to prevent any dissection or complications. And then we are going to go 6.
Okay, no, 6.
Okay, that's it. So leave this there to prevent any contamination, but retrieve the balloon, leaving the wire in place. Okay. So you cannot see the wire because he's quite obese. We are ready, Valeria. We can move from there. You can disconnect. And we can leave it here so we are not contaminating. Okay, perfect. Okay. Give me the balloon. So after this inflation, we are going to change the wires. Let me clean my hands.
I have it.
Okay. Do you have the other balloon?
Yes.
Okay. Oh. So you can inflate there. 1, 2, 3, 4. Give me the other balloon.
4.
Okay. So probably will take some time from the second case. Let Dr. Fava knows that we are going to take some time here. So probably you might inflate here where I have some difficulties, probably due to this wire. And now inflate here. Okay. 1, 2, 3, 4, 5.
Yes.
Okay, 5 here. 6, 8.
8.
Both are 7. It's okay?
Yes.
Okay.
Yes, sir.
Deflate. Agarra, Joaquín, un insuflador. 1, 2, 3, 4, 5, 6. 8 on the left.
8.
Es el
8.
8, 10.
10.
Okay, deflate. Vos también. Let's go here. 1, 2, 3, 4, Gustavo. 5.
Yes.
6.
6.
7, 8, 10.
Right.
We have there some balloon indentation. On the external is okay, but on the internal we have still a, let's move up. Let's go here. Let's go here. Okay. No, this one. This one.
This one, the right one.
Yeah. 10. 8. Okay, I think it's okay. Leave it there. Give me the one of the unplugged wire. Let's go to the more panoramic view. This wire is finished. Let me take it. Okay. Show me arriba. Okay. So now Gustavo is going to retrieve the balloon. Yeah. Now give me the right coronary catheter, the 6 French catheter. Although we have the renal mark with the stent, we will put the catheter just in case. As always. Could you bring the device, please? Gustavo, could you receive the
Yes,
device?
of course.
And Joaquín could help me. Joaquín, vení conmigo.
Okay. 28 or 26?
I think 26. 26. Okay. Ariel, suggest 28. Okay, that's it. Test. Give me more fluoro. I have to see where the renal stent is. No fluoro. Yeah, okay, I see.
28.
Patient is quite obese. Move forward. Okay, deflate this balloon. Bring the unplugged wire. Unplugged. Probably here we can use an extra stick, the Landerquist. Yeah. So to prevent movement there. Yeah. Okay. We have a lot of calcification, so it's going to be a movement there. So probably it's better, okay, to go with an extra stick. And we save the. Ayúdale ahí. Dame a mí. Ayúdale a Gustavo que no se le vaya a caer la prótesis.
Okay.
So this is Landerquist, extra stiff wire. Although it's a low profile device, I think I'm going to have to push hard to advance.
It is
And
good.
hopefully it will advance. Okay, so now Dr. Lev is going to retrieve the balloon and hold the sheath. And now is the time for the truth, as we always say here in Argentina. Vení, Joaquín. Tenés la inglés. Please, comprimí bien. So Ariel is here just to prevent any incorrect movement. All devices have tips and tricks, and it's important to remember. So here I'm going to introduce it first, and then we will see what's going on. So we have resistance, but not too much. And I think we are more than successful and more than happy with this. It's okay, Joaquin. So give me a little bit zoom.
To show the landmarks?
Yes, we have to orientate the landmark. Zoom. Please stay. So first is the proximal marks exactly on the inferior border of the renal stent. I'm not going to use contrast media. Then we have the capital I orientation. Give me this. I can use the, well, sorry, this. The I orientation here, to be sure that the device branches are going to be side-by-side orientation. Is that correct? Okay, so now I have to release the security here. Let me clean my hands. Moving forward this device and then start to rotate, keeping the alignment of the device. The device is trying to move up. I try to keep there and I try to keep the orientation. I rotate counterclockwise. So remember, I had to go very close to the renal arteries due to this hostile proximal neck. So now I have delivered the contralateral side, hold it there. I have to unscrew here and to release the proximal fixation device. And there you have observed the delivery. This okay? Enough or more? Okay, okay, perfect. So a minimal test is regarding the renal position, it is perfect there, just small shot, 2 cc's. Okay, it's okay, Joaquin. Now, this is important step. I had to catheterize the contralateral branch. I need zoom. I usually use the row runner guide wire. Here, I need a pin for rotation. When the wire touches something, it's because you are very close. Okay, Gustavo, move it.
I'm sorry. No, sorry.
But there, when you feel this touch, it's probably because you are in. But here, I don't think so. We are in the wrong position. So let me see. Hopefully, we don't waste too much time on this. Please, obliqua. Okay. So here, zoom. Probably we need a catheter with a little bit more, or like a Lima or something like this. Without.
Okay.
Estamos, Mario. I think with the Lima catheter, we will have a better alignment. Let's try.
Hi.
I think
Yes.
I am in. Okay. You see. So now, please, AP, zoom. So it's normal to feel some resistance when you are trying to enter to the contralateral side. And arriba. So we also, if you are doubtful, remember that you can rotate the catheter here inside the main body. If it is rotating freely, like here, you are absolutely sure that you are in. Now it's time for the ampla square. Mostrarme más abajo, might need a marked pigtail, el pigtail marcado. So he's a young patient. We try to keep the hypogastric artery open, although it has a significant osteal disease there. So we don't have to go too low with the contralateral branch. So fortunately, the patient is absolutely stable now. Nothing to do with the patient that we started the procedure at the beginning. It was a really tough situation again. So I will dilute the contrast just to inject very few amounts and mostly water, or actually saline. Let me see. So we have almost 10 centimeters until the hypogastric artery. Give me something. Okay. This is water. Flow mapping, please. We are not using the vessel navigator, not because we don't like it, but this patient underwent a CT scan in another center, and the quality is not good enough to put here. So I think we need a 10, yes. Okay. Well, could be shorter, pero 140, 120. Okay. 120 is okay because we have 10 centimeters outside the device and 3 centimeters for overlapping. But once again, remember that this is not an aneurysmatic iliac artery. It's just an stenotic iliac artery. We don't have to put too much stent there. We open very nicely with the lithotripsy balloon, and then with the complementary regular balloon. So Dr. Gustavo and Dr. Joaquin, remember that Joaquin is from Ecuador. He has a lot of friends watching the case from there. Yeah, Andres. Clear. How we, the question is, how would we manage in this patient the antithrombotic treatment? I think here in this patient, the mandatory issue is gonna be the left main stenting. So it's a patient with panvascular disease, young patient, not stroke. Of course, he has a COPD, so probably we have to discuss between, wait a minute, Joaquin, I need your help again. We have to discuss between ticagrelor and prasugrel plus aspirin for at least for 3 months. And then we can probably move to monotherapy. But in this patient, due to his so severe COPD, probably prasugrel would be, and being young and without strokes, prasugrel would be better. So finally, I would say prasugrel and aspirin, DAPT for at least 3 months, and then single therapy for 1 year. Let's, I think we are perfect there. So let's see, here is 3 cc for overlapping, and we will see where is the distal part here. So the distal part is over the hypogastric artery here, which is here. So I'm gonna go a little bit upper. So I will take the road mapping out because he's too obese and we don't have good imaging. Tacal mapping. And now we might check with Ariel about the overlapping proximally. Let's go más arriba. So here, so markers should have a coincidence between the contralateral stump of the main body and the volve, Joaquin, and the iliac stump. So you are okay there. So you would rather like a little bit down, but I think I can pull during delivery. Let me know if you are happy there. I think it's okay. So now it's a perfect coincidence there. So I can push the device a little bit there, just to make a little bit shorter. Gustavo, keep rotating. I will push a little bit. Okay, okay. So we should release the proximal fixation. Mostrame más arriba. And now, which is free, Rotavo would rotate, and I'm gonna más abajo. I'm gonna shorten a little bit the device.
Rotate it.
Yeah. Excellent. So now the proximal retention or security retention wire was released. Now I can disconnect from here, and Gustavo can retrieve, leaving the wire in position.
No.
Yes. The delivery system, and we have the introducer here. I'm not gonna do tests again, just to prevent the using of renal. I want to post-dilate with a compliant balloon.
Okay.
Here, the iliac artery and the proximal neck. And then I will release the homolateral branch. And we will introduce the homolateral branch. So this is the special balloon is well aspirated. We have a lot of resistance. ¿Ese es new? No, I need the dedicated balloon.
This is the balloon for the.
Aspirate again.
Okay.
Le mantengo aspirado.
Okay. Should go in. I feel resistance. Now it's better. Probably it's better aspirated now. Suéltalo. Okay, now it's better. Now I am pushing everything in. I'm going to inflate there. I have a good inflation there. Hold the wire, Joaquin. I'm going to push everything all together. Inflate, Gustavo. Just to achieve a rectangular configuration. It's okay. Let me go up there. This is the connection between stump and main body. Perfect rectangular configuration. Move up. And now I'm gonna go to the proximal neck. Here is a problem. I'm trying to go below the renal stent. That's why I didn't want to put the stent protruding. That we usually protrude 1 or 2 millimeters, but here I made a different decision. You can inflate the air a little bit. Okay, you can push the wire. Push. Metela, empujala. The wire is. Vale, yo lo hago. Déjalo. Okay, Gustavo,
okay.
deflate. So Gustavo, push the wire
Yes.
and then you can retrieve the balloon. While Joaquin is aspirating. Aspirating, please.
Okay.
Yeah. following me? Seguime. Okay, let's go. Push the wire. This sheath is absolutely hydrophilic, so you have to take care of not losing the position on the groin. So once again, I would accept that the outcome is okay. I will release the wire there and complete the delivery of the main body. And now we have to recapture the proximal part.
You have to.
¿Lo avanzo? Okay. So Ariel is recommending me to disconnect and using Gustavo is going to push the wire. Mostrarme arriba. It's important to see that you are going back very smoothly. Here, seguime. Now we are into the introducer, so Gustavo can go out perfectly. Safe. So I'm more than happy that we could cross such calcified iliac arteries. So now, once again, we might need the pigtail with marks, marked pigtail. El pigtail marcado.
Yeah.
We still have 10 minutes for this case, at least. Maybe we can use some minutes from the other. The other is a regular PCI. Hopefully, we don't have so many problems down here. Hopefully. So,
En el contraste, en la jeringa.
From this side, the external iliac artery is occluded, so we don't have reference. So we had to decide where it's going to be the landing zone. In my opinion, it's going to be near the roof of the bladder. So I think 122, 120 is going to be okay because we can cover all this area which was dilated. Tenemos 10 más 2, 9 o 10 más los 2 de overlapping. It's okay?
Sí.
Okay.
Would you like to do a roll mapping?
No, because I don't have a hypogastric here, so I don't have landing mark.
Okay.
Probably si tenés 13, well, sí, 13. I think 13 is much better. The iliac artery is very small. Remember, it's 9 or something like this. 16 is going to be too big. So after deployment of this branch, we're going to do ballooning, then the angio, and then hopefully we are finished. In this patient, I thought that if we have proximal endoleak, we might introduce a EVAR stent. But after doing left main, left renal, and the EVAR, I don't know if it is too much procedure, and probably I should wait for 1 month and bring the patient back and doing.
So in this case, IVL was successfully done because to prevent perforation, dissection, access complication at all.
Any complication with the fatal because such instability of this patient. So sorry for the noise. We have to release the device from the package. Another good issue from this device is that it has inline sheath. So this is a 16 French sheath that we can use as a regular sheath to introduce the homolateral branch. Dr. Lev is
activating the
and humidification the coating.
The coating, yes.
Which is completely hydrophilic. So now here we need to clock the device like now. So it's completely fixed. And we can advance all together. The sheath was not advancing. Let me rotate and move a little bit. Why? Mostrame más arriba. Okay. Give me oblique. I have some problems here, and now I absolutely in.
Yes.
Okay. Okay. So markers are okay. Let me sacar la digital. Let me shoot some cine
Frank,
to be
in
sure.
front.
No. Here. So I think markers are okay. Okay. But we can pull because we push all the device in. So after delivering, I can pull a little bit. What do you think? Okay. I am pulling a little bit. I am releasing the device here. Is that okay? Let's do cine to see much better. This is one limitation of the device, is the radio opacity. Of course, it's so thin that the radio opacity is very low. Okay, probably let's release this part, the proximal, now to disconnect here and to pull everything out. Give me the balloon. We will check the outcome. Let's vamos a P. And then we will decide what to do with the iliac artery. Probably we can use regular stent or cover stent. That we have authorized also a cover stent to use here. Let's, okay, it's enough because let's go there. Okay, deflate, inflate, deflate. Careful that this device is soft. No muy fuerte, Gustavo.
No.
There. Okay, enough. Let's do an angio. And then we will decide what to do with this iliac artery. Let me introduce all together a little bit. Okay, remove. Retira. Give me the pigtail, el regular, panoramic. Because we don't have retira. Hypogastrics, so we had to aspirate here. Let's see. Okay, here. Gustavo, you might inject. This is contrast or water?
Water.
Okay, I will aspirate here so we can have flow on the iliac artery. Que no respire. Okay, stop breathing. Inject. Oh, I think we have some porosity there because this is not proximal leak. This is a porosity leak. So it's type 4. We need to revert the hyperimmunization and then everything is going to be okay. The right iliac artery is okay.
Yes.
What? Yeah.
No,
yeah,
yes.
okay.
We know. No, it's okay.
So let's see. Give me the wire.
Yes. Which
the
one?
Amplats?
The Amplats.
Sí. La izquierda.
Bueno, mira.
Sí, voy a testear ahí. Let me check the right side. Let me put the wire, the ampler,
Yes.
please. Okay, and we are going to introduce 13 by 80, so we can cover all this area, and then we can dilate this area at high pressure with a regular balloon. Take it out, Gustavo. Dámela. So the graph
going to
here, it's important. No, I will
Okay.
introduce. This graph has a lot of porosity. So you need to wait for a heparin reversion and then the anxio follow-up. No. During the time. Now we cannot revert the heparinization because we have a stent on the left main. I know. So that's why I'm gonna close the groin. But if we have some bleeding, Gustavo is gonna handle by a long compression because sheath are not too big. So I think we might need to compress because we cannot revert the heparinization due to the stent on the left main. And I can move to the other room. Con un 8. So we are going to post-dilate the external inside the branch with 8. So once again, we need the connection here. The click, I can advance all together. Have some resistance there. I think we are okay there. It's okay? Perfect. So, okay, yes. So we have 2 or 3 centimeters overlapping. I don't move up. This is the coincidence between the 2 branches. Okay, and it's released. I release the nose. Okay, and Gustavo can move out. Give me the
balloon.
The balloon. Yes. Patient is absolutely stable. Unbelievable. I think left main stenting was the right decision. I had to be honest. Gustavo was more convinced than myself. Okay, inflate Gustavo there. 10, 12. Okay.
12.
Deflate. Once again. Dame water, un poco de agua.
12.
Okay. Take it out. Okay. Take your time. Take your time. It's okay.
Okay.
Yes. Inject Gustavo a little bit here. Inject. Okay. Let me see. Digital. Okay. Acá. Ahí nomás. Okay. I think we have a
It's okay.
dissection there.
It's outside of the prosthesis, isn't it?
Yeah, because we are injecting there, we have two branches there. Probably calcium have ruptured the prosthesis. Give me one of the cover stent. We will sure that this is fixed. El stent forrado. We will put 1 or 2 cover stent there. 9. ¿Y el 8 cuánto es? No, 9. I'm going to put the 9. millimeter cover stent there because we have extravasation there. Probably the calcium have ruptured the graft of the device. And then I'm going to put a stent in the outflow. Okay. ¿8 por cuánto? 960, okay. Let's see. We are going here. Okay, I think this stent is gonna be enough for everything. I think it's something is wrong here on the measurements. Let me deliver the stent. No, I don't touch it. Hold it there. Okay. Okay, perfect. Retrieve. Yes. Let me check. Is necessary dilatation or no? Okay. Give me some water. Oh, now it's
Wonderful.
beautiful. Okay, we are done. We don't need to post-dilate. And I think the stent was longer than Matthias told me. Move here. We are going to close. Give me light. Keep the wire. Trae el 6, Gustavo. Toma, Joaquín. No, vamos a intentar. We are going to try to close without heparin reversion due to this left main stenting. Okay. So Gustavo is going to pull the device. Okay. Okay, no, I hold it and introduce the 6' sheath. So we might see if we need an additional angiosyl or no. Let me see how the situation is here. I think it's acceptable. You see, I don't have too much bleeding. Thumb, comprime. Can you? Okay. No, de cerrado. Okay, 1, 2, 3. It's okay. Now, okay. Okay. Now release. Release. Cargalo. I think everything is in control. So probably we can pull the wire. We can pull the sheath. We can pull the suture. And then we have to compress for some minutes.
Goodness.
Y quizás le podemos revertir la mitad. Because there is so much calcium here. Afloja. The situation is quite stable. You see, there is not much bleeding. I move to the other side. We will do the same. Sorry for taking 10 minutes from the other case, but this is an absolutely extraordinary case. Okay. So do you have the 6? Okay.
Yes.
So 3. Patient is okay. Take it out. Leaving the wire and introduce a 6 French sheath. Just in case we had to introduce an additional angioseal. You might observe the obesity of this patient and how difficult this patient would have been for surgery. So the situation is absolutely stable here. Fortunately, despite the calcification, the suture is working. Let me see, no mix. And then Gustavo and Joaquin would compress for a while until everything is okay. While myself and doctors, soltame un segundo. It's okay. Take everything out. So as you can observe, there is just a small oozing, that's for sure. It's going to be fixed with some compression. I think it was, I know that the device has some other limitation, but this is the only device that we could have used here. So I would say, let me move to the other side. Thank you for this case. I'm going to move, if you open the camera, I would say bye. And Zoom, please. Okay, great. Here. Great. The case is done. Thank you, Gustavo. Thank you, Joaquin. Thank you, everybody.
Thank you.
It's an absolutely unusual case. I think it was very successful. And I'm going to move to the other lab to do this PCI with Dr. Fava. Thank you so much for helping us with all your questions.